Hi, I'm Alicia Duyvejonck. I am a nurse practitioner and a headache specialist, as well as a program director for Genesis Headache Clinic in Davenport, Iowa. I'm here lecturing on COVID-19 and headache today, and this lecture is going to be posted on a couple of different websites, both APP to APP, Virtual Lectures Inc., and My Catholic Doctor. So some objectives today, we're going to review the relationship between viral illness and headache disorders. We will discuss the prevalence and clinical presentation of acute and post-acute COVID-19 symptoms related to headache and primary headache disorders, as well as identify features associated with secondary causes of post-COVID headache and identify some management strategies for these patients. So before we get into COVID-19 specific information, I want to start with the relationship between headache and viral illness. This is not a new concept. This has been documented over centuries. And we actually have a diagnosis that was created in 1986 called New Daily Persistent Headache, or NDPH. This was initially identified by Dr. Van Ast with a case series of 45 patients studied over a year, and they identified that these patients had daily headache from onset with no preceding headache history, and these headaches weren't attributable to other causes. So this certainly is not a new issue, but has definitely become a more prevalent issue as we've gone through this kind of post-COVID era. So the diagnosis of New Daily Persistent Headache is identified as daily from onset. In fact, many patients that have this disorder recall the exact date that their headache started. If your patient can come into your office and tell you the date that they started with a daily headache, this is your diagnosis. NDPH is often a patient's first ever headache, although I will tell you that it is common for patients with primary headache disorders to have new daily persistent headache. And this would involve a distinct and sudden change in that person's headache frequency, characteristics, and or associated symptoms. Here we see the ICHD-3 criteria for diagnosis of new daily persistent headache. That's actually one of our most simple headache diagnostic criteria. We simply need a distinct and clearly remembered onset with pain becoming continuous and unremitting within hours. And this headache has been present for more than 3 months and not better accounted for by another diagnosis. Interestingly, you do not need to have any specific phenotype or associated symptoms to have a diagnosis of new daily persistent headache. So a little bit of prevalence and incidence information. There was a study that was done in 2004 that identified a sudden onset progression in 30% of patients progressing from episodic to chronic migraine. So typically, progression in migraine is a little more gradual, usually seen over days to weeks. So that's those other 70% of patients, but 30% is not a small percentage. So this does happen in our migraine population. Another study that same year showed 43% of new daily persistent headache was associated with febrile or viral illness. And also kind of interesting that we see higher rates of new daily persistent headache with seasonal variation. So we see more of this in the spring and the fall, which is also the time that you see peak of viral illness. Although I will also say that we see similar seasonal variations sometimes in primary headache disorders, such as migraine or cluster headache. New daily persistent headache is difficult. This is a huge challenge for us as providers and for patients. It is actually identified as one of the most treatment refractory of all headache conditions, likely because we have a very poor understanding of the pathogenesis. A single theory of pathogenesis for new daily persistent headache is very unlikely because there's actually multiple disorders and situations that can cause sudden new onset daily headache. Not only viral illness, but initiation or discontinuation of medications can occur. We can see new daily persistent headache after extracranial surgeries that involve intubation. We can see it with thyroid disorders. So there's all different kinds of events that can lead to this condition. So it's very unlikely that there's a single underlying etiology, which does pose certain challenges. There are a few distinct patterns that we've identified for primary new daily persistent headache. You can see a self-limited form, which means that this is resolving spontaneously within a couple of years of onset, regardless of what we do for the patients. There's a refractory or progressive form, which means that the headaches continue for years to decades, regardless of what we do for these patients. And then a relapsing remitting form, which means the daily headache starts and stops, but may recur later. So on to some specific COVID-19 information. So as many people know, there have been over 500 million confirmed cases of COVID-19 worldwide, and headache is a common symptom of COVID-19. The prevalence is 25 to 49% in the COVID population, and headache is the 5th most common symptom of COVID-19 infection. There is a higher prevalence of COVID-19 associated headache in patients with a prior history of primary headache disorder. And the median duration of an acute COVID-19 associated headache is about 14 days. Now, what about long COVID? So that's more the acute COVID headache. We also see patients with post-COVID headaches, and these are usually associated with patients who are being diagnosed with long COVID. So the World Health Organization has established a diagnosis for this. The patient needs to have a history of probable or confirmed COVID-19 infection. And the headache usually starts within 3 months from onset of the COVID-19 symptoms. These symptoms the symptoms are new in onset following the initial recovery of COVID-19 infection, or they can simply persist from the onset of the COVID-19 infection. And these can relapse and fluctuate over time. The diagnosis cannot be explained by an alternative diagnosis, and typically these symptoms are lasting at least 2 months after the acute infection or after the onset of symptoms. In addition to headache, other common symptoms are fatigue, shortness of breath, and cognitive dysfunction. And these symptoms are significant. These aren't just little mild symptoms, oh, I feel a little tired. These are symptoms that are significant enough that they're affecting day-to-day life and patient function. COVID-19 and headache, we know that long COVID is becoming a progressively serious issue. We are now seeing declining mortality rates as we learn how to treat COVID. Of course, with that, we see more post-COVID issues. There are low rates of spontaneous headache resolution in patients dealing with post-COVID headache for more than 2 months. So we really need to treat these patients because they are not generally going to get better very quickly on their own. And like I said, with the new daily persistent headache patterns, it's possible that some of these patients are going to be going through this for years. So it's really important that we get these patients treated. 19% of COVID patients in a study that I looked at experienced ongoing headache for at least 3 months. After onset, and 16% were still experiencing it after 9 months. So these are not resolving quickly. There is some mixed data regarding the prevalence of post-COVID headaches when you look at mild versus severe acute migraine symptomology. And I'll kind of speak to this on a future slide, but really the bottom line is we're getting some mixed results, so we need more research on that. So post-COVID headache and primary headaches. So I have told you that patients with primary headache disorders are more likely to have post-COVID headaches. And that's one of the things that's being seen on this slide. One study indicated that 16% of migraine patients had chronic migraine pre-COVID, and that increased to 65% being chronic migraine after a COVID infection. So really high rates of progression from episodic to chronic migraine with post-COVID headache. In addition, delays in care are super common, and that contributes to poor outcomes and disability. You have to treat these people early. The earlier you intervene with these headache patients, the better they're going to do and the less likely they're going to deal with ongoing headache issues. Most patients, however, are not receiving specialty care for 3 to 12 months after their COVID infection, and 43% of these patients are not being started on preventative medication after evaluation. So we, quite frankly, just need to do better. COVID headache pathophysiology, this is largely unknown. Just like that, the information I gave you on new daily persistent headache, there is probably more that we don't know than what we do know. But a few things that we do know, just like many other headache disorders, there is a genetic predisposition and often a prior history of headache. Also, like many other headache conditions, there is an involved trigeminal-vascular system activation that is underlying. We think that in COVID-19 headache and other virally associated new daily persistent headaches are at least in part due to a persistent activation of the immune system. But we also see gray and white matter and functional connectivity changes when we look at MRIs and functional MRIs. So as I said before, COVID-19 does affect patients with primary headache disorders, but patients without history of primary headache disorders can also get COVID-19 related headaches, and that would be considered more of a secondary headache, often attributed to the systemic viral infection and subsequent immune response and cytokine release. There also can be vascular or non-vascular issues going on as contributors. When we see migraine patients with post-COVID headaches, that can be for a variety of reasons. Migraine can be triggered by the viral infection itself, just like we said with the patients without primary headache disorders. But there's a lot of other things that could be triggering some of this, or at least contributing to some of this in your migraine patients. First of all, this is a very stressful event, right? Both the infection itself and the symptoms, the fact that they're missing work, maybe they're not able to take care of their family, maybe there's anxiety and concern about transmission, and as well as all of the stress that kind of honestly comes with the pandemic, you know, the isolation, the decrease in activities, all of these things. So, you know, some patients may be having increased migraine because of letdown from stress, or from the stress itself, or maybe some traumatic experiences that were experienced during their infection. And that can all lead to migraine progression. In fact, we see this even with other stressful events in our history. There's actually been studies done, for example, with some of the mass shootings. We've seen increased rates of headache and headache progression in patients who have been involved in mass shootings. We saw this also after the attack on the Twin Towers in 2001, extremely high rates of progression of migraine from episodic to chronic. So we do see these things even outside of viral illness. So those certainly need to be those factors certainly need to be taken into account as well. There is, as I said, some immune system activation that's likely driving some of this. Headache during acute COVID infection can be associated with a more efficient immune response and overall improvement in patient outcomes. But as I said before, since I made this slide deck, that's actually there's actually been some mixed studies. So just because you have headache doesn't mean you're going to have a more mild disease. Just because you have more severe COVID-19 symptomology acutely doesn't mean you're not going to deal with post-COVID headache. So the jury's still out on that. We do see elevated cytokines and interleukins with long COVID patients, and this may indicate persistent immune system activation as a contributor to symptoms. And we also know that chronification of headache is common in immunocompromised patients. So the immune system is definitely involved here. I do like to just touch on this hypoxia and hypercapnia issue. I think early in the pandemic, We thought that perhaps this was one of the driving forces behind COVID headache and post-COVID headache, but there has been quite a bit of research, surprisingly, on this. And what we find is that oxygenation and hypercapnia is not a driving force behind COVID headache. We do know that there's structural and functional brain changes that we see with post-COVID headache. This was a really cool study. There's a longitudinal study that actually started before the pandemic. They were going to study something else in regards to brain function, but then pandemic hit. So we have this really great cohort of these patients where we have baseline imaging, and now we have post-COVID imaging. And we have seen that the MRIs are showing increased gray matter reductions in areas functionally connected with the primary olfactory cortex, which can be involved with some of these symptoms, as well as weakened functional connections that have been noted on functional MRIs within several areas of the brain. So I thought that was a really interesting study, and kind of, I don't want to say lucky, but almost lucky that we got to see these patients before COVID, and now we're able to follow them after COVID and see some of what happens to them. There are some risk factors for post-COVID headaches. So this will kind of help us identify who do we need to be worried about as far as ongoing post-COVID headache, because remember, I said we have to intervene early. If we can intervene early, we're going to make a huge difference in these patient outcomes. So patients with previous history of primary headache disorders are going to be at risk. Female patients are going to be at higher risk than male patients. And patients that deal with post-COVID fatigue and loss of taste and smell with COVID also are at increased risk for post-COVID headaches. So make sure that those patients that you identify these factors in, you're really considering progressing to treatment of their problem. Phenotypes for post-COVID headache is almost anything. Post-COVID headaches do not have their own presentation other than that new daily persistent headache. We can see migraine phenotype, tension type headache. We can see trigeminal autonomic cephalgia phenotypes such as cluster headache or hemicrania continua, as well as cranial neuralgias. So it's quite variable, although migraine and tension type headache presentations are the most common. Patients do have autonomic symptoms. About 13% of those patients will have those, maybe redness, tearing, sinus congestion, these kinds of things. And the long-lasting headaches are very common. More than 50% of patients with post-COVID headaches have a daily headache. And these are often associated with tinnitus, fatigue, dizziness, and cognitive difficulties. We do want to make sure that we identify secondary causes of post-COVID headaches, just like we do with any headache. In fact, this slide comes out of many of my other lectures. Some of you may have seen this slide before. This is our SNOOP5 mnemonic. So this is how we remember what to look out for to maybe indicate risk for a secondary cause of patients' headaches. So systemic signs or symptoms, neurological signs or symptoms, especially if they're new, sudden onset headache, or really what we're talking about here is a thunderclap headache. So going from zero head pain to severe head pain within 60 seconds, always a medical emergency. Patients who have onset of their headache after 50 years of age, patients who have new onset headache in pregnancy, or that patient who has a progressively worsening headache or a change in their previous pattern. Maybe that migraine patient, like I said, who was doing well and now has a new daily persistent headache post-COVID or not post-COVID. We want to look for positional aggravation. So patients who tell you that the headache significantly worsens or comes on with supine position versus upright positioning, that can lead to concerns regarding intracranial pressure, either high or low pressure. And you always want to inquire about headaches precipitated by Valsalva or physical exertion. Specifically, post-COVID headache things that we're seeing as serious causes of post-COVID headaches include cerebral venous thrombosis, That's rare. It's occurring in less than 0.1% of hospitalized patients, but it is an important one to identify if it is going on. That one actually usually has a delayed onset post-respiratory disease, usually around 13 days or so. And a third of those patients do have other cardiovascular thrombosis risk. So smoking, use of birth control, older age, cardiovascular comorbidity, these kinds of things. We can see PRES, or posterior reversible encephalopathy syndrome, that is a cause of post-COVID headache. Headache is a less common symptom of that condition, but it can happen, and it's important to identify. These patients are usually ones that are having severe COVID disease. That's usually who we're seeing ending up with PRES. There are occasional associations with cervical artery dissection with post-COVID headache, so that's important to identify as well. So treatment approaches. So finally, we're getting to some talk of what do we do with these patients. First of all, I really want providers to start screening for headache in all COVID patients. Whether you're seeing a patient for acute COVID or long COVID symptoms, make sure you're asking the question, do you have headache? You know, patients may not offer up that information, especially if they have an underlying primary headache disorder. They may not think anything of the fact that, hey, I'm sick, and so I'm having a migraine. You need to ask these patients about those symptoms. Treatment of post-COVID headache is usually consisting really of standard of care treatments for whatever their headache phenotype is. So if their headache phenotype is migraine, we give them migraine treatment. If it's a cluster presentation, we give them cluster headache treatment. Tension type headache presentation, tension headache treatment, and so on and so on. We also want to consider comorbidities with other post-COVID symptoms when we consider medication. If someone's having a lot of post-COVID fatigue and cognitive impairment, maybe we don't want to give them something that's going to make them more fatigued or have more memory impairment, for example. We do want to assess for red flags, warranting further evaluation, as we said on the previous slide, and refer refractory cases to those or those with concerning red flags to specialists. So there, of course, as you might expect, be fairly limited studies regarding COVID headache treatment, but there are a few. One study using amitriptyline 25 to 75 milligrams nightly resulted in 44% of those patients achieving at least 50% improvement in their headache. We've also seen really good results with indomethacin. And I really found this quite interesting. Indomethacin not only improves the headache, but it also improves dry cough associated with COVID infection through anti-inflammatory action and inhibition of viral protein synthesis. Now, I'm not a COVID expert, but it just is pretty interesting to me that maybe we have this medication that could help with both aspects. There was one small study that evaluated the use of indomethacin 50 milligrams twice daily with pantoprazole 40 milligrams daily for 5 days to treat COVID headache. And the majority of those patients had at least 50% improvement. So that's I think, a good treatment option. And of course, additional research is always needed for something that is this new of a problem. The rest of the slides that I'm going to go through, really, I included in here because I thought it would be good information for you. This is not specific COVID headache information. This is actually information on migraine and other primary headache disorder treatment, because I told you that really what we need to do is treat them with standard of care outside of these couple of studies that specifically looked at COVID headache that we already talked about. So this slide just outlines the options for acute headache treatment. We, of course, use analgesics, NSAIDs, acetaminophen, aspirin, combination products, triptans, or ergotamine products like DHE, whether that's IV, IM, or oral or nasal spray, and of course the Gepants and Ditans, which are newer products in the migraine space. Just a couple of things that I would point out. If you have suspicion for cardiovascular risk in general, of course, for any patient, or maybe even more specifically, concern regarding cardiovascular complications of COVID or secondary vascular causes of post-COVID headache, like we've talked about, you really do want to stay away from those triptans or ergots because those can cause vasoconstriction. So if you have any of those concerns, I would stay away from those classes. The gepants and ditans, in my clinical experience, there's no research on this at all, but I have had patients who are responding to them, but they will need a migraine diagnosis. Although I will say, even if they don't have a history of migraine, if their headache is migrainous and does meet migraine criteria, you can give them a migraine diagnosis and potentially utilize some of these options. Acute migraine strategies, also not specific to COVID-19 headache, but I think that it's good information since we're going to be using standard of care for whatever their phenotype is. Stratified care, which is the one at the bottom, that's actually the best recommendation from the American Headache Society. You know, using a toolbox of treatments, different medications based on the situation or the characteristics of the headache. So I may use option A if I have a headache that develops during the course of my day over, hours. I might be able to catch that with this product. If I wake up from sleep with a very severe attack that we weren't able to catch early, you may need a different option. Also, not every headache's going to respond to the first line treatment, so it's often helpful to have a second option to use as rescue if the first option wasn't effective. You can do step care across attacks or within attacks. So seeing if one thing works, and then if it doesn't, then the next, then going to something else, whether it's within the same attack or across attacks. That can be helpful, but in kind of your more complicated cases, I definitely would recommend going to a more stratified care approach. This is an overview of headache preventative medications that we can use for migraine, tension type headache, and or cluster headache. Antidepressants, the tricyclic antidepressants and SNRIs have the best evidence. With antihypertensives, we have best evidence for beta blockers, calcium channel blockers, and ACE inhibitors. I'm going to put a plug. I don't think that there's been a lot of research in it, but when I've talked in kind of my circle of headache specialist colleagues, there's been a lot of discussion about use of angiotensin converting enzyme inhibitors specifically. I'm using a lot of candesartan for post-COVID headaches, for example, in my clinic. Again, that's more expert consensus type information, not necessarily research evidence-based. We do use anticonvulsants, topiramate, Depakote, lamotrigine, sometimes gabapentin. And then you get to more migraine or cluster-specific treatments with Botox, CGRP, monoclonal antibodies, and gepants. There's also a variety of non-pharmacological therapies that are important. I always say, I can throw medicine at people all day long, but headache in general is a very complex issue, and almost everything in a person's life is going to contribute to headache in one way or another. So there's a lot of importance to non-pharmacological therapies and lifestyle modification. So those things are very important as well. There's lots of great data in headache in general for treatment with physical therapy, neuromodulation devices, acupuncture, biofeedback. Some patients can benefit from osteopathic or sometimes chiropractic manipulation, massage therapy, CBT, or pain psychology. And then, of course, I've already mentioned the importance of lifestyle modification, exercise, stress management, diet, hydration, all of these issues. So these are the references for some of the information that I've given you today. And I really appreciate your time and attention, and I hope you learned something useful.